Thank you very much for inviting me. It's a very pleasure. I'm very pleased to be here with you, even if only by internet because of technical troubles that we had. In my talk, I will present some new data and some new ideas on the problems related to HIV vaccines, broadly neutralizing antibodies and cure for HIV, hopes versus hypes. There are many points for clinicians that must be taken into consideration. In fact, despite decades of efforts, we have no HIV vaccine which has a protective effect, and trials are not really enthusiastic. The presence of broadly neutralizing antibodies is important, and there is a major scientific breakthrough, but the clinical development is not fully reached, and there are many problems that I will try to show you in a moment. HIV is very diverse from the genetic point of view, and there are very rapid mutational capacities, so this is a barrier to the vaccine-induced passive bNAbs antibody protection. In fact, bNAbs antibodies can transiently suppress viremia and can delay the rebound, but there are no long effects about that. The combination with different bNAbs is a tool, but at present there are no indications that this works better than only one bNAb per time. RNA vaccines are interesting. They offer a renewed optimism, but current human data are very early phases and do not demonstrate the ability to induce a protection in a long period. There are many cure-oriented strategies, including the reversal of the latency, immunomodulation, gene editing, but again, none has achieved consistent, durable remission. The reports of functional cure often reflect short-term post-treatment control, short terms, even if in this case, in our case, we have patients who have been treated for dozens of years and all works. The antibody, the bNAbs antibody may find a clinical niche in the prevention, especially if long-acting formulations are used, but again, the system has to become feasible and cost-effective. So at present, ART remains the only reliable, scalable, and durable therapy. Which are the mechanistic overview of current therapeutic strategies? Of course, we can have the combination, as I mentioned, of different bNAbs, as you see in the slide. We can have we can use RNA-based vaccines with different parts of the virus that can be immunogen. We can have different cure-oriented strategies, such as the shot and kill, on-immune therapies, immune enhancement, gene editing, and so on. We have functional cure signals. Functional cures means that you can treat patients with ART for a long time, then you interrupt treatment, but in most cases the treatment interruption has to be stopped and people have to restart to take drugs because of the again the virus comes out again. We can use bNAbs in the prevention of the infection, but again the problem is the escape of the virus to most antibodies that recognize different epitopes. And finally, we have the antiretroviral therapy, which is reliable, scalable, and durable. And this is done all over the world. But which are the problems with DNA or RNA vaccines for HIV or even protein vaccine? The main problem is that we have to target rare naive B cells that are responsible for producing antibodies in the blood, and these cells are very rare and not easy to reach. Second problem is the fact that these cells have to mature and origin plasma cells that produce bNAbs, which is again a main issue. We have troubles with the sequential immunization of people, so we can have different doses, different time periods, and this should lead to the maturation of B cells and to the hypermutation of antibodies that become more and more specific and with a high affinity for the virus. And this is a problem because it is very difficult to go in the real world and to have a good feasibility and scalability. There is a problem of the models. we have different human animal models against the virus. I mean, HIV or humanized mice or humanized other rats and so on. But the problem is that the difference between men and animals is very high, it's very strong, and we do not have the same type of response, even to the same kind of vaccination. So in the real world, all attempts were not working well. So the first attempts with the GP 120, then with viral vectors, and then with mosaic immunology, I mean different, up to 60 different epitopes in one single molecule to induce a very strong and a very good immune response. But which are the promises and the constraints of the use of bNAbs? They should work. They work well when they are present and they can block the virus for a long time. But there are big problems with the manufacturing and the cost of the antibodies. There are problems with the insufficient half-lives of these antibodies because they are rapidly degraded, and every 2 or 3 months you have to inject again the antibodies to the patients. You need a combination of antibodies to prevent viral escape. I mean, you need antibodies that recognize different epitopes of the virus, and this is not always feasible and quite complex from the technical point of view. And finally, we have to understand the viral sensitivity to the testing challenges and use assays that are fast, non-expensive, and clinically scalable, especially as far as the sequence of the virus is concerned. So we should improve the access to all this kind of analysis. But which is the core barrier for the vaccination and also for the bNAbs? Of course, the mutational capacity is very high because the virus changes a lot. We have a global and intra-host diversity with different clades. We have a rapid replication and a continuous mutation of the virus, so this escapes to all the immune system products. We have several epitopes which are conserved among viruses, but they are very hard to access because of the presence of glycans on the surface on the GP120 and so on. And finally, there are many unpredictable and unavoidable pathways of escaping from different strategies with vaccine or with bNAbs. So actually, in this moment, the passive administration of bNAbs can improve the viremia, can decrease the viremia, but again, as I mentioned, the suppression is only transient, and the virus comes out again, and it's very difficult to reach a long viral control. And there are several combination antibodies that are tried now in different trials. I mean, to use different antibodies against different epitopes. But again, the problems are those that I mentioned before, that is the logistical burden, the increased problems in the manufacturing, the costs, the variability in the virus, and the limited use of assays that are able to detect the virus, even in all the smallest and most, but not so evident, I mean, mutations. So, which are the cure-oriented strategies? So we have the possibility to use reversal agents to induce transcription of the virus, but this does not work in eliminating cells. There are several immune-based interventions that lead to a transient control of viremia and an increase in the number of specific CD4 and CD8 cells against the virus, but the virus, the reservoir, can persist in immune-privileged sites. We have attempts on gene editing approaches. Promises and limitations are very great. I mean, the processes are great. We can cut and paste the DNA. We can do a lot of nice things with CRISPR-Cas9 system, but the delivery in vivo is actually very poor. We have to understand how to reduce the reservoir in order to have a functional cure, and in this moment, when you stop treatment, the reservoir starts to work and you have a viral rebound. The anatomic reservoirs are often very difficult to access and very difficult to reach with different drugs. And finally, we have a strong problem with the proliferation of target cells that can proliferate and replicate the virus if the virus is not blocked. So the point is that in the reservoirs we can have the expansion of clones that maintain the reservoir. And which are the barriers? Again, as I mentioned, we have studies with a short-term suppression we can reach a plateau of control, but again, if you stop treatment, you have to restart again the therapy. There are people who are, as we know, exceptional controllers of the virus, like long-term non-progressors or elite controllers, but they are very rare, and we have still to understand which are the genetic protections and which are the genetic reasons according to which these patients can control the virus for a long time, even without therapy. And then we have the problem of the overreaching, again, the reservoir with bNAbs, with vaccines, or with other methodologies. So the functional cure, we know that we can reach the control of the virus with ART. We know again that exceptional individuals can control the virus. We have a delayed rebound, and there is lack of durable ART-free suppression across different individuals. So every individual that undergoes a sort of treatment interaction is different from another. So the personalization of therapies, the personalization of cure is absolutely important. And so ART remains the only reliable, scalable, and durable therapy. So we can have consistent, lifelong viral suppression. We can prevent the disease. We can prevent the progression of the transmission. We have now long-acting formulations that support the adherence. And finally, we can have superior scalability and cost effectiveness of ART in comparison with all other type of attempt of treatment patients. So ART remains the main treatment of patients. And with this, I thank you very much for your attention. I apologize for not being in India, which is a fantastic place. I really would love to have been there. And I say